Ali. Dr. Ali graduated with summa cum laude with honors in South Carolina Honors College and earned her medical degree from Medical University of South Carolina, where she was inducted in Gold Humanitarian Honor Society and received the Julius Siegel Award for Excellence in Internal Medicine. She completed her residency in internal medicine at University of Florida, serving as chief resident with a focus on quality improvement and patient safety, and went to complete her fellowship in hematology and oncology at University of Florida, where she was honored with Innovation Award. Dr. Ali is currently a breast medical oncologist at Cleveland Clinic main campus. Her research interests focus on developmental therapeutics and improving outcome in patients with recurrent and metastatic breast cancer disease. Please join me in welcoming Dr. Ali.
Thank you, Zanara. That was such a kind introduction. And of course, you guys see me struggle with the my screen share. I think I'm sharing this screen, right? Let me make sure I'm sharing the correct screen here. Maybe I should share this one. Okay. And okay.
We can see the slides now, Dr. Ali.
Okay, you see the slides, but you don't see the presenter mode, right?
Yes.
Yeah, it's not presenter mode.
Okay, thank you. Thank you so much, Zanara, for the kind introduction. I am very excited and honored to be here for the second part of this. So in this installment of management of metastatic hormone receptor positive HER2 negative breast cancer, we were going to cover part 2, which is essentially beyond endocrine therapy. These are my disclosures. So here's the agenda that we covered, some of it in the first session. So we talked about first-line endocrine therapy in the last session. We talked about second-line endocrine therapy, which is essentially beyond CDK4/6 inhibitor treatment. And today we will talk about what is beyond endocrine therapy. Let's get rid of this. And where are we with antibody-drug conjugates? So this is what we discussed last time. As you all might recall, we talked about in the first line, we often utilize aromatase inhibitor plus minus ovarian function ablation for those that are young and premenopausal with the CDK4/6 inhibitor. We also utilize fulvestrant with the CDK4/6 inhibitor in those that have had a progression on aromatase inhibitor in the adjuvant setting, or they recently completed their adjuvant therapy. There is that sort of additional endocrine resistance subgroup. These are patients that have had a progression either on adjuvant aromatase inhibitors or within 12 months of completion. And if they have a PIK3CA mutation, we do have the option to add this sort of upfront triplet with the alpelisib, fulvestrant, and palbociclib. In terms of second line, we went over this last time. For mutation in ESR1, we have the option to include elacestrant. There's also some rising emerging data with imlunestrant and some of the other SERDs. For PIK3CA mutation, we've had alpelisib for several years with fulvestrant. We have a much, I would say, a rather newer approval with capivasertib for the last 2 years. And this is an AKT inhibitor, which can be used for the PIK3CA AKT P10 pathway alteration. For germline BRCA mutations, whether these are germline or somatic, actually, there is data to use PARP inhibitors. There's also data to sequence CDK4/6 with CDK4/6. So again, it's obviously a different CDK4/6 than what the patient received in the first line. There is data with endocrine therapy, everolimus, and then there's also some emerging data with imlunestrant and abema, which is not yet approved. This is, again, a quick refresher transition from the last session. And I put this up here before we transition into antibody-drug conjugates to make a point that, dilemma in breast cancer treatment right now is once we get that sort of first-line therapy with CDK4/6 inhibitor, if you look at our median progression-free survival is anywhere in the 6 to 8 month range on average, sometimes even worse for a select subgroup of patients. And they don't really get a lot of durable response until we get to chemotherapy or antibody-drug conjugates. So this brings us to this clinical unmet need, where there is an unmet clinical need in patients that are post-endocrine therapy, post-CDK4/6 inhibitor, as activity of those treatments that I just showed you, even though they're biomarker-driven, the benefit is really modest. I think another problem we have is that sequencing is unclear, and some of those patients just don't have the biomarkers that we have drugs for. Historically, we have utilized chemotherapy in that setting. So these are these endocrine resistant patients. Once again, we're talking about HR positive, HER2 negative metastatic breast cancer. And even chemotherapy in that setting can be associated with low response rate, poor prognosis, and significant toxicities. So this brings us our natural segue to antibody drug conjugates. These represent a novel strategy to deliver cytotoxic payload to a target cell, improving therapeutic index and exerting effect on the neighboring cells. So here is the mechanism of action of antibody drug conjugates, and perhaps this is not a complete surprise for this audience, but just as a reminder, this is sort of the classic mode of action where we have an antibody drug conjugate. This little guy here is the payload or the cytotoxin, or what I tell my fellows, that is the chemotherapy, right? So ADC will bind to the receptor that it is sort of designed against. That whole combination will get internalized by endocytosis, and once it's inside the cell, this will exert its cytotoxic effect. And of course, that comes from the payload, which again is the chemotherapy. What's cool about this mechanism is that this allows us to deliver a lot of drug. So these drugs have a high drug to antibody ratio, which means they have more intratumoral efficacy. So that's the classical mode. There's also kind of a second method by which these drugs work, and that's called the bystander killing effect, which means that as the drug is binding to the receptor, that payload or that chemotherapy can actually diffuse through the cell membrane, which is permeable, and the drug can exert additional effect on the tumor cell and the neighboring cells. So antibody drug conjugates, we have 3 drug approvals in the US in this situation. We have trastuzumab deruxtecan that requires HER2 low or ultra low expression. That is approved after endocrine therapy prior to chemotherapy. We have sacituzumab govitecan. This is approved after endocrine therapy and 2 additional lines of systemic therapy. We have datopotamab deruxtecan. This is approved after endocrine therapy and 1 additional systemic therapy. So I want to take a brief moment to talk about HER2 because the HER2 landscape has evolved over the last several years in breast cancer and some other tumors, but primarily breast cancer. So historically, we've followed the ASCO-CAP definition for HER2 low positivity and negativity, and that basically is membrane staining that is complete, intense, and greater than 10% of tumor cells, and that is the HER2 score 3+, which is a protein-based assay, and the 3+ would be essentially positive. There is another way to be HER2 positive, and that is the weak to moderate staining, greater than 10% of tumor cells, or membrane staining is intense, but less than or equal to 10% of tumor cells, what the pathologist would call 2+, and then a reflex FISH DNA-based test, if that is amplified, and that's the ratio that's listed here per the ASCO-CAP, and cells can be HER2 positive at that definition. HER2 expression 1+, that has incomplete membrane staining, faint, barely perceptible, but greater than 10%. This used to be HER2 negative, but now we have realized that there's actually some benefit with some of the treatments we're going to talk about. So that has kind of a new designation of HER2 low. So technically, anything that's 2+ with a negative FISH and 1+ where we would not really FISH per ASCO-CAP, those would be HER2 low patients. Now, in the last couple of years, we have an even additional category in the HER2 lows, and that's the membrane staining that's incomplete, faint, that's less than or equal to 10% of tumor cells. So we've been talking about greater than 10%. This is like that 0 to 10%. And that is the HER2 ultra low staining. So what if there's no staining? This is now called HER2 null or HER2 negative or HER2 IHC 0. The reason why we care about this is because 60 to 65% of HR positive, HER2 negative metastatic breast cancers are going to be HER2 low, and 20 to 25% are going to be HER2 ultra low. And if you add these numbers up, these could be up to 80 to 90% of patients that we have historically classified as HER2 negative patients, and we have not offered them a HER2 directed type therapy that we now have a new treatment option for. So this brings us to trastuzumab deruxtecan. This is an antibody-drug conjugate. This consists of an anti-HER2 IgG1 monoclonal antibody with the same amino acid sequence as trastuzumab, hence the name trastuzumab deruxtecan. This is a topo-1 inhibitor payload, which is the deruxtecan. This utilizes a cleavable tetrapeptide-based linker. This has a very high drug-to-antibody ratio, which is actually 8:1. So I typically tell my fellows that think about how much drug that is. That is so much more potent than chemotherapy that we couldn't give that much chemotherapy without a ton of cytotoxicity. I'm sorry, there we go. Internalization of TDXD leads to release of DXD payload via the mechanism I just showed you. And there's also kind of like that bystander effect where the drug is absorbed from the membrane, as I showed you. Okay, so here's the data from the landmark Destiny Breast 04 study. This was a major study presented at ASCO 2022. I remember the study was so exciting, got a standing ovation. So for our refresher, this is a study that included HER2 low patients, IHC 1 plus or 2 plus with a negative FISH, unresectable metastatic breast cancer treated with 1 to 2 prior lines of chemotherapy. These were patients that were classified as endocrine refractory. Additional strat factors as listed below. Patients were randomized 2:1 to TDXD at the standard dose, and treating physician's choice of chemotherapy, or TPC, which was CAPE, eribulin, gem, Taxol, nab-paclitaxel. These are the primary endpoints: progression-free survival by blinded independent central review, or BICR, in HR-positive patients, PFS by BICR in everybody, OS HR-positive in all patients, and here are the additional secondary endpoints. The initial analysis of DB04, which we saw in ASCO 2022, that demonstrated a superior PFS and OS versus TPC in HR-positive HER2 low patient cohort, with a PFS advantage from 5.4 months to 10.1 months. So that's a 5-month PFS advantage in this metastatic patient population. In addition, we saw an OS advantage from 17 months to 23 months. So that's again about a 5-month advantage. We have now seen some additional data at ESMO 2023, and we will actually get into that very shortly here. So here is the ESMO 2023 data. We will start with the OS overall survival, or OS probability. And this is the HR positive cohort that shows an improvement from 17 months to 23 months. Again, very similar to primary analysis, so no big surprises here. What about in all patients? So again, a 16-month to 22-month gain. Again, very similar to our initial primary analysis with a very similar looking hazard ratio. So once again, we see that TDXD improves median OS versus TPC in this HR positive cohort and all patient cohort, and about a 6-month absolute benefit in overall survival. What about PFS probability? So this is the HR positive cohort and all patient cohort. Once again, we see in the updated analysis, there's about a 5-month gain, very similar to the primary analysis in HR positive patients. And there is about a 4 or 5-month gain, once again, in all patients, similar to the primary analysis. So no surprises here. And more importantly, the effect that we saw did not get lost over time. So what are the conclusions from Destiny Breast 04? Updated results of DB04 with 32-month median follow-up confirm the superiority of TDXD versus TPC for patients that are HR positive, HER2 low. There are significant improvements in both overall survival and progression-free survival, and they are maintained. With longer treatment duration, the safety profile remained acceptable and manageable. Their main toxicities are GI, fatigue, bone marrow suppression, and most of them are grade 1 and 2. Incidence of ILD is 12%, mostly grade 1, 2. There was 1 patient death on this study that was educated secondary to ILD. These results supported the use of TDXD for HR positive HER2 low metastatic breast cancer that are considered endocrine refractory after at least 1 line of chemotherapy. All right, this will bring us now to Destiny Breast 06. So DB04 established the efficacy of TDXD in HER2 low MBC metastatic breast cancer after 1 to 2 lines of chemotherapy in endocrine refractory setting. So DB06 then attempted to evaluate, what if we offer TDXD even earlier? We know this is a very active drug. Can we address that disease even early on and change the biology of the disease with a much active drug, even ahead of chemotherapy? So as we just discussed, 60 to 65% of patients that were previously historically designated as HER2 negative are in fact HER2 low. And then the additionally 20 to 25% of those patients are HER2 ultra low by the definition I just showed you. So Destiny Breast 06 actually included the HER2 ultra lows, which again expanded the patients that are eligible to receive this. So here is the DB06 design. This is a phase 3 randomized multi-center and other landmark study. HR positive metastatic breast cancer. These are HER2 low, IHC 1 plus or 2 plus with a negative FISH, or HER2 ultra low, that is IHC 0 with any membrane staining 0 to 10%. These are very important chemo naive patients. So now we're going straight from endocrine therapy to ADC. Prior lines of therapy, 2 or more ET plus targeted therapy, or 1 line of metastatic breast cancer, plus progression under 6 months of starting first line, or recurrence less than or equal to 24 months of starting adjuvant ET. So these would be what we would describe as primary endocrine refractory. These are the strat factors as listed below. These patients were randomized 1-to-1 to receive T-DXd at the standard dose versus TPC, and these are the options listed: CAPE, nab-paclitaxel, and paclitaxel. Here are the endpoints, very similar to what we saw in DB04. And chemotherapy, I think this is a fair point to mention, that in the TPC arm, majority of patients had CAPE, about 60%, which I think reflects a very real world practice. We do often go to CAPE after endocrine therapy. It's an oral chemo. Patients get to keep their hair. They don't have to come to infusion clinic. CAPE was followed by nab-paclitaxel, which was about 24%, followed by paclitaxel 15%. At data cutoff at initial presentation, 14 patients remain on treatment, 20% on T-DXd, 7.2% on TPC, and median duration of follow-up at the time was 18.2 months. Okay, so here are the demographics. If you kind of look very, if you glance at the demographic table, it looks very balanced. I do want to point out some key things. Of course, the demographics are balanced. 153 patients were ultra low, as noted here. These are the patients, again, that would not have historically been given this drug. 30% of patients had primary endocrine resistance. Those are the patients that we again saw that had a quick recurrence, or they had recurrence on endocrine therapy. 30% were de novo. 85% had visceral mets. So that is right here, visceral disease at baseline, and 67 to 68% had liver mets. And bone-only patients were actually 3%. So this is a really high-risk patient population that were given this drug in this trial. So here are the results. This is the primary endpoint, which was PFS by BICR in HER2 low patients. You see a delta improvement in PFS from 5 months, from 8 months to 13.2 months. So that is statistically significant, hazard ratio 0.62 with a significant p-value. What about intention to treat population? So that's all comers. Once again, a very similar trend, I would say, 8-month improvement to 13-month improvement, that delta gain of 5 months. Again, a very good looking hazard ratio of 0.63 and a significant p-value. Now, HER2 low and intention to treat population OS trends. Remember, at the time of presentation last ASCO, this data was at 40% maturity, but we see actually very encouraging trend in the probability of OS improvement. So about 5 to 6% gain. So 81% versus 87% gain in HER2 low patients, and a very similar trend, once again, about a 6% gain from TPC to 87% in all comers, which was HER2 low plus ultra low. What about PFS and OS and ultra low? So again, that's the patients with any membrane staining 0 to 10%, patients which would not be considered HER2 low by the former definition. Interestingly enough, we see a very similar looking trend. Now, one could argue this is a very small number of patients, it's only 152 patients, but I would say this is still very good data that we can generate. There's a 4.9-month improvement from 8 months to 13.2 months in terms of probability of PFS. In terms of probability of OFS, remember, this is at only 40% maturity, but still about a 6% gain in OS, which looks very good. So what about anti-tumor activity? I personally find the objective response rate data very interesting and very practical because that's the data our patients are asking for when they come to us in clinic and they say, what's the chance of this drug working, right? And we can kind of quote that data and say, well, that's the chance of that working, or that's the chance of clinical benefit rate that your disease may be stable. So as a reminder, ORR includes CR and PR, and then clinical benefit rate will include CR, PR, and SD. So if you look at those numbers, 32% to 56% improvement in HER2 low patients, a 31 to 57% improvement in intention to treat patient. These are again all comers, and a 26% to 61% improvement in HER2 ultra low. If we look at the clinical benefit rate, we see a very similar trend that we are improving the life of these patients with bringing this drug upfront. What about treatment-related adverse events? So on the right, we see TDXD. There is more nausea, more fatigue, more alopecia, more LFTs, a little more neutropenia. These are side effects seen in greater than 20% of patients. That's why we don't say ILD, because it's relatively rare. So main toxicities, once again, similar to DB04, are GI, fatigue, bone marrow suppression. Most of them are grade 1 and grade 2. So what about ILD? I do want to take a few moments to talk about ILD. ILD is an important adverse event, and it's an adverse event of special interest. In DB06, we can see, I would say, similar to a lot of our older Destiny studies, we see that majority of the ILD is early grade. So 2% grade 1, 8% grade 2, 0.7% grade 3. So again, majority of them are grade 1 and 2 events, but there were 3 patient deaths. And these are educated as drug-related ILD, which means that there was an independent review that determined that this was drug-related. So that remains an AE of special interest, and I think this is why there's a lot of hesitance to use this drug up front, because we do keep seeing these grade 5 events from this drug. In terms of left ventricle function, I think this is pretty consistent through all of our Destiny studies, that most of these side effects are rare. Most of them are grade 1 and 2 events, and we have not seen any deaths from EF reduction. In terms of cardiac failure, once again, most of them are early grade, and you can see they're really rare. So educated as drug ILD in DB06, 11.3%. Okay, so this is very interesting. We have seen now at SABCS 24, we saw additional follow-up data for Destiny Breast 06 that Dr. Bardia presented. And the reasoning, the rationale for these analyses was to investigate the benefit of TDXD in patients with different responses to ET, and that's endocrine therapy. And what we are learning is that there's a lot of heterogeneity with our breast cancer patients. No 2 breast cancer patients are the same. So for example, time to progression on that first-line endocrine therapy plus CDK4/6, as we discussed last time, that's kind of become a surrogate marker of how patients may do on the subsequent lines of therapy. Are patients primary or secondary endocrine resistant? What is the efficacy of TDXD in this sort of post-endocrine line setting of subsequent therapies post-progression on TDXD? And time, this is the essentially PFS2, which is time from randomization to second progression. So not the progression on this line, but the progression on whatever they get next, which I would argue PFS2 is now sort of becoming a surrogate marker for OS in a lot of our studies, because sometimes it might take a while to get to the OS events. And now a lot of these ADCs are approved and available commercially, as I will get into. These patients are going to get off the study and get an antibody drug conjugate. So it is going to be very difficult, and it's going to be very muddy to kind of clean out that OS data. So PFS2 has become a very important endpoint. And then what's the benefit of TDXD in patients with varying disease burdens, right? Does the tumor burden, does the tumor extent, does the tumor location matter? So here is the PFS by time to progression on first-line ET plus CDK4/6 inhibitor and endocrine resistance. I understand this is a busy slide, but we'll try to dissect it. So these are the patients that had less than 6 months on their first line, right? So their CDK4/6, these were patients that had kind of that quick progression. What we see here is there is a gain from 6.5 months to 14 months. And at a glance, you can see that this might be the greatest delta that we see, right, compared to those that had 6 to 12 months on the first line endocrine therapy or over 12 months. And we could argue these patients had a much faster disease, and they were likely to get the greatest benefit, and their PFS by chemotherapy was going to be the shortest compared to the other two groups. The bottom line here is whether they had a quick progression on the CDK4/6, or they got 6 to 12 months, or they got over 12 months, everybody benefited from going to T-DXd first versus chemotherapy. They are all hazard ratios that are significant and p-values that are significant. What about PFS2, which is what I told you, which is the time from randomization to not this progression, but the next progression, which is kind of like our surrogate marker for OS right now. And we actually see an improvement from 14.7 months to 20.3 months. And this is, I think, very important. And I want to slow down here and let everybody absorb that data. So again, less than 6 months on the first line therapy, improvement from 15 to 18 months. Again, we can argue that these are patients kind of like fast progressors, 6 to 12 months, 13 to 17 month gain, and in over 12 months, 14 to 20 months gain. So these are what we're saying by this data, because I think when we first saw the DB06 data, one sort of critique that I can tell you I personally had is that I know patients anecdotally that have done really well on capecitabine, right? They're infusion free, they get to keep their hair, we can dose adjust, and it's manageable, and we're not worried about cardiotoxicity, and we're not worried about ILD, and we all have patients that have done well for years. So the idea is, well, why use it now when we do have the option to use that drug later? When I saw the PFS2 data personally at SABCS, that has made me sort of second guess my rationale or my approach, because this is telling us that we make the change early in the pace of disease with bringing a more active drug, that patient may do better overall because we have changed the disease more effectively and we have gotten smarter than the cancer. So with this data, I think was enough to convince me to use this drug up front, unless somebody has a lot of toxicity, unless somebody really prefers to stay infusion free, and they really don't want to get to an IV therapy. But I think this data is incredibly important. What about PFS by measure of disease burden? So if you have less than 3 local or metastatic sites at baseline, there is a 6.9% 9-month advantage. What if you have 3 or more local metastatic sites? There is, again, advantage either way. And we can argue these patients are kind of like higher risk, so they do worse on chemotherapy than those that have fewer sites of disease. And maybe you don't get as much gain from T-DXd, but this is much worse disease that we're dealing with. So once again, PFS benefit is all across patients that have less disease or more disease. So here are the conclusions. T-DXd demonstrated a statistically significant and clinically meaningful PFS benefit when compared to chemotherapy. This is, again, post-endocrine therapy, pre-chemotherapy. Results in HER2 low are consistent with HER2 ultra low. Benefit of T-DXd is seen regardless of time to progression on first-line endocrine therapy plus CDK4/6 inhibitor, primary, secondary endocrine resistance. Included patients with rapid progression, those with low disease burden, no new safety signals. I want to take a minute to address the ILD question. This is a review that I published last year. And this kind of looks at our older trials, DB01, DB02, DB03, DB04. This is, of course, before we saw DB06 data. But if you look at the treatment toxicity across all Destiny trials, these are, again, this chart here represents grade 3 or more toxicity. You can see that grade 3 or more toxicity, most of these are cytopenias, right? You can appreciate neutropenia, anemia, thrombocytopenia. Nausea, yes, and I would also remind everybody that NCCN now considers T-DXd as a high emetogenic drug. So we are now using aprepitant as our chemotherapy regimen, and I think that has really helped the nausea issue quite a bit, and the vomiting issue as well, I would say. In terms of ILD, grade 3 or more ILD is generally rare, right? These are going to be like low single-digit instances. We don't want to ignore the patient deaths, though, because that is a sort of an avoidable issue. In terms of all grade ILD, I would say this is my sort of experience and kind of what we're seeing across all Destiny trials time and time again, that it's about a 10 to 17% incidence. I do want to bring your attention to the number of previous lines of therapy. So in studies where the lines of therapy were 7, we see 17% ILD. If prior number of lines was 6, we see 13% ILD. In trials where prior number of lines were 2, we see about 10%, 15%. I guess DB03 had a lot more high-risk patients. But again, it's about it's about a 10-13% risk. So there is the sort of discussion, we bring the drug up front where patients are not heavily chemo treated, we are going to see much less ILD. And I would say we have seen that so far. We will now switch gears to sacituzumab govitecan. This is a highly selective TROP2 directed antibody drug conjugate. The drug to antibody ratio is 7.6 to 1. Remember, TDXD was 8 to 1. Very similar mechanism with internalization, enzymatic cleavage. I want to point out the active ingredient is SN38, which is the same drug, active drug from irinotecan. Hydrolysis of linker releases SN38, similar mechanism to what I just showed you, and currently it's approved for second line and later. Metastatic triple negative breast cancer for HR positive, HER2 negative metastatic breast cancer after endocrine therapy and 2 chemotherapy lines. So here is the sacituzumab study. This is TROPiCS-01. These were metastatic, locally recurrent, inoperable HR positive HER2. I love that the drug company and investigators point out here that IHC did not matter. Point taken. Breast cancer that progressed after 1 endocrine therapy, CDK4/6, and 2 lines of chemotherapy. So very important to know what I showed you with DB06 is no chemotherapy, DB04 at least 1 chemotherapy. Patients were randomized sacituzumab govitecan to treating physician's choice of chemotherapy. Very similar endpoints to what we just saw. So here is the primary analysis. There is a significant improvement in PFS, as you can see, a gain from 4 to 5.5 months. A median OS also advantage, and this is statistically significant. I bring that up because we're going to see another ADC after this where the OS advantage was not met. And this is the 11-month to 14.4-month gain. Objective response rate, 14 to 21%. So this doesn't look as good as what I just showed you with TDXD, but remember, these are heavily pre-treated patients. Duration of response, 5 months to 8 months. And I'll show you some further data. Demographics and baseline characteristics generally balanced. I want to bring your attention to sort of the disease burden of these patients. Visceral mets at baseline, 95 patients. I think this is number of patients and not percentages. Liver mets, 84 patients, and de novo metastatic, about 22 to 23 patients. Median lines of prior therapy, 60% of patients had 3 or more lines of chemo. So again, they're very heavily pretreated, and about half of them at 2 or less. Progression-free survival, there is a 4-month to 5.5-month gain with the hazard ratio that I want you to remember, 0.65, because I'll show you another hazard ratio with datopotamab deruxtecan in a few minutes here. The p-value here is significant. What we see with the PFS probability is that effect is maintained. Overall survival, there is an overall survival improvement. The delta is about 3 months, but the statistical significance is met here with the hazard ratio 0.79. Overall survival by TROP2 expression, this has been an ongoing question. This is a TROP2 directed antibody. Is there a benefit in patients that have a high TROP2 expression, defined by an H-score equal to or greater than 100 versus low TROP2? And what we have seen with SG time and time again, that the H-score does not matter, so everybody benefits. What about overall survival in HER2 low and HER2 IHC? I think this is done to tell people that this drug is not dependent on HER2 IHC like some of the other ADCs I've shown you, and essentially there's benefit regardless of the IHC designation. So response endpoints, overall response rate, we see a benefit from 14 to 21%. In terms of clinical benefit rate, we see an improvement from 22 to 34%. So there's an improvement in ORR, CBR, and extended duration of response. Safety, I think this is sort of expected. No big surprises here. Neutropenia, anemia, thrombocytopenia remain the big side effects. I would say GI side effects still remain very common and prevalent among these studies. Alopecia is very intense with SG, fatigue, asthenia, decreased appetite, and some sort of rare side effects like dyspnea, headache, pyrexia, and LFT changes. So conclusions in the exploratory analysis with extended follow-up, which is 13 months of TROPiCS-OT, TROPiCS-02 SG demonstrated superior efficacy versus TPC among patients that are pre-treated, endocrine resistant, improvement in PFS from 4 to 5.5 months, and overall survival 11 to 14.5 months, response rates and prolonged duration of response. Benefits are seen regardless of TROP2 expression, and in both HER2 low and IHC 0 patients. Safety profile is manageable. And I think once again, important to know that there's no new safety signal. This brings us to our third ADC. This is datopotamab deruxtecan. Dato-DXd is an ADC composed of three components. So this is another TROP2-directed IgG1 antibody, tetrapeptide-based cleavable linker covalent binding to antibody. And this is also a topo-1 payload, which is the deruxtecan, similar to trastuzumab deruxtecan. The drug-to-antibody ratio is 4. So I showed you 7.6 with SG and 8 with T-DXd. So this one is 4, which about TDM1, by the way, is also about 3.6 or 4. This has a highly stable linker. It limits systemic exposure. So the idea is that there is sort of left off-target toxicity, so better tolerance. And there is the bystander anti-tumor effect that we see with all ADCs. This mechanism is very similar to what I already showed you with some of the other ADCs. So here is the TROPION-Breast01 design. This is the randomized phase 3 study. Patients included were HR positive, HER2 negative breast cancer, previously treated with 1 to 2 lines of chemotherapy, experienced progression of endocrine therapy. These are the other strat factors as shown, randomized 1-to-1 to Dato-DXd, which starts at the standard dose of 6 mg per kg versus investigator's choice of chemotherapy, ICC. These are the endpoints, again, very similar to the endpoints we're seeing in all of these ADC trials. The study met its dual primary PFS endpoint, which was PFS with Dato-DXd by BICR per RECIST and overall survival. PFS was improved from 4.9 months to 6.9 months, and ORR improved from 22% to 36%. And then I will briefly show you that data. Here are the demographics and the baseline characteristics. We can see, I think the biggest thing to point out here is the prior lines of chemotherapy. Majority of these patients had just one prior line. So 61 to 63% had just one line. The other had 2 lines, so nobody had more than 2 lines of chemotherapy. Majority of these patients did have prior CDK4/6 inhibitor. Here is kind of the breakdown of prior taxanes and anthracyclines, and here the HER2 status breakdown. Here is the PFS data. There is PFS improvement from 4.5 months to 6.9 months. I think the thing to point out here is that the hazard ratio is very similar to what I just showed you with TROPiCS-02 with SG, doesn't it? And these are sort of less heavily pretreated patients than the SG patients. And in terms of the statistical endpoints, it did meet its primary endpoint. Overall survival, I'm sorry, it's cut here. What we see here is that there is, I guess, bare numeric improvement, but essentially there's no difference. There was this sort of suggestion of OS improvement, and the curves do come together. So OS is not statistically significant, and maturity is 60%, but that is one problem with this data set. I think this is important data to look at, and I think this is what I was referring to when I said that PFS2 is going to be very important for some of these trials. Because if you look to see what patients get after they get off the study, this shows you that in a world where we operate, where we have ADCs commercially available, that patients that come off the study, they can get ADCs, and as they should, but that can really make our OS interpretation very difficult. For example, from the TROPION-Breast01 study, 12% of patients in the Dato-DXd arm got an ADC in the next line, but 24% of patients in the control arm got an ADC. So twice as many patients had access to or exposure to an ADC. That could mean that that's why the control arm looks so much better. Now you can go back and look at the numeric numbers and say, well, the numeric numbers didn't look that much better, even in terms of overall survival, based on the data that we have seen from the DB06 and DB04. But I think once again, that could explain that we now have access to SG in the subsequent line, and we have access to T-DXd in the subsequent line. So Dato-DXd OS adjusted. So what the investigators did with this publication, they actually adjusted for the subsequent lines of therapy, which makes the control arm look a little worse than the OS arm, but the data is still not significant, and the hazard ratio still crosses 1. So here is the secondary efficacy endpoints and the final analysis from TROPION-Breast01, which was presented at ESMO 2025. And this is the PFS investigator assessed. So 4.5 to 6.9 gain, PFS2 10.4 to 11.7 gain. This is treatment-free interval 5.2 to 8, and then 12.3 to 13.7. In terms of overall response, 22 to 36% improvement. CR is obviously low here with a lot of these refractory patients. Duration of response, 6 to 7 months, and disease control rate at 12 weeks, 66 to 80 months. Safety signals, there is nausea, stomatitis, which is a side effect of special interest. So is the dry eye and the potential of needing eye exams and eye drops. Other than that, I would say in general, my experience with this drug, similar to traditional chemotherapy, I think the stomatitis and the keratitis and the dry eye, those are the symptoms that require a lot of monitoring and support. So TROPION-Breast01 safety treatment-related emergent events in greater than 15% of patients. I think this is a very important slide because every time a new drug is approved and we have new side effects to monitor and side effects to screen for, I think these are the things to pay a lot of attention to. So in terms of oral mucositis and stomatitis, you can see that majority of these events are grade 1 and grade 2 with stomatitis, and 7% were grade 3. Now, this study, I don't know if anybody participated in this study, but most of these sites were global sites where we didn't have Dex mouthwash available. So in the US, all the patients that we enrolled, we had to have patients get Dex mouthwash. So when we use this drug here, we give Dex mouthwashes to everybody. So I think when you look at some of this data and see how much, stomatitis we saw, they might have not gotten a lot of optimal control of that if the Dex mouthwash was not available. What about ocular surface events? Again, 32% were grade 1, 10% were grade 2. Agitated drug-related ILD, that looks very low risk with this drug. So what are the TROPION-Breast01 conclusions? TROPION-Breast01 met its dual primary endpoint of PFS1. There is a statistically significant improvement with Dato-DXd versus ICC. The dual primary endpoint of OS was not statistically significant. Is it because of the subsequent ADC use that I showed you? But then they adjusted that for the subsequent ADC use and it's still not meeting statistical significance. Is it just a not as effective of a drug as SG or TDXD? The secondary efficacy endpoints, they do continue to favor Dato-DXd over chemotherapy for what it's worth. And overall safety profile is acceptable. There are few unique toxicities to know about. That's the keratitis, stomatitis. They're generally low grade, manageable with prophylactic strategies. So here is the summary of ADCs. So I want to point out TDXD is a anti-HER2, SG and Dato-DXd are both TROP2 directed antibodies. The payload for TDXD is a topo-1 deruxtecan. Dato-DXd also has a topo-1 inhibitor, deruxtecan. And as a reminder, TDXD and Dato-DXD are made by the same company, AstraZeneca Daiichi. So maybe that's why we have some mechanistic similarities. Half-life of these drugs, TDXD has a half-life of 5.8 days. Dato-DXd has a half-life of 5 days, and SG has a half-life of 16 hours. Drug to antibody ratio, we have talked about this already, 7 to 8, 7.6, and 4 to 1. Efficacy, so where is the data currently? DB04, HER2 low, 2 lines or more, PFS benefit and OS benefit. DB06, this is upfront post-endocrine therapy, HER2 low, HER2 ultra low, first line, technically, right, post-endocrine. There is a PFS improvement, OS suggestion of improvement, though data is not mature. TROPiCS-02, this is the SG study, HER2 low, HER2 IHC0, basically HER2 status did not matter. These are second line and beyond patients. These were heavily pretreated patients, as I showed you. PFS improvement, OS improvement. Tropion Breast-01, second line or beyond, but they were less heavily pretreated than the SG patients. Very similar PFS, but OS was not met. Drug side effects to watch out for: nausea, fatigue, ILD, SG, neutropenia, diarrhea, anemia. I would also add alopecia, dato-DXT, nausea, stomatitis, and dry eye. So wrapping up the session, we kind of started out here with the first line and the second line. I would say in the three-line option, we're now operating in an era where we have access to TDX, to antibody drug conjugates. So now we have options like trastuzumab deruxtecan, HER2 low or ultra low. Technically, chemo is out there. There's cytotoxic chemotherapy or datopotamab deruxtecan, but remember that did not meet overall survival. Sacituzumab govitecan, remember that requires 2 prior therapies, so that could be kind of like a third line option in that setting. Of course, there's the good old cytotoxic chemotherapy, and we should be considering clinical trial for all of our patients at any of these checkpoints. I think I still have a few minutes to take questions. I would be happy to take questions. Oh, oops, can you guys still see me? I don't know what just happened.
We can see you, Dr. Lee.
Oh, okay.
I'll just see if on the question box they have any questions.
Yeah, no problem.
I'll be waiting for questions from the audience if they have any questions. So Dr. Ajay has asked if there is sequence of ADC matters,
Yeah,
and I
that's a
was thinking
very
the
good
same.
That's a very good question. So, the sequence question, I guess the sort of the broad problem with the sequencing we have, right, is that um, in our trials, right, our patient populations are so carefully selected, right? We can designate how many how many prior lines of therapy. So I think we don't always get that information from our trial patients, especially with now, depending on where we operate and depending on what access we have to antibody drug conjugates, that subsequent line therapy can really decide how well patients may do from an overall survival standpoint. So, to Ajay's point, the way we get that data is from real world data. And we are seeing some early reports. So Laura Hubbard has a presentation and a paper out, I believe this past month or a couple of months ago, in NPJ Breast, where they did kind of a multi-institutional analysis of ADCs to see, like, who did better, on the first ADC versus second ADC. That was primarily TDXD versus SG. And what we see time and time again, that patients do better on whichever the first ADC is, right? So if your ADC is like TDXD first, that ADC, the TDXD time was better than the second ADC. Same thing with SG. I think there were some suggestions that SG patients might have done better, but it's a very small subset and it's not a very large patient subset. Um, I think another important question that's arising, and that had been, well, do you sequence ADCs like ADC to ADC, or do you do the ADC chemo sandwich ADC, right? And historically, I have felt comfortable to do the ADC to ADC, but I'm now sort of questioning my practice with some of the data that I'm seeing. So, for example, Paolo Tarantino published, I think that's also in the last month or so, where they did kind of a similar center review of patients. And they actually see is that if you do an ADC and you put a chemo in between, and then you go to the next ADC, those patients may do a little better from a chemo timeline and the second ADC standpoint versus if you go ADC to ADC. So with that data, that's making me question, I guess, what I'm doing. And I think for the right patient, I might utilize that approach. I think we have to realize there's a lot of limitations with that data because this is real world data. There's a lot of patient factors we are just unable to control. And sometimes, patients are coming off the drug because of a drug toxicity and not lack of benefit, right? And so when we get the real world data, there's so many things that we can really adequately account for. But I agree with the comment that the sequence does matter.
Thank you so much. I also have one question, Dr. Ali. In your real practice, how often do you screen for ILD in TDXT patients?
That's a very good question. So, screening, I think the more and more we learn about that drug, I think the push is to screen for ILD. You all might have heard of I think it's the five S's or the six S's, right? The screen and, test and refer. So I would say I started out not screening people, just kind of watching as for symptoms. More so now, I'm screening more. I don't know if the optimal sequence of screening is clear for ILD. If my patients are getting CTs anyway, CTs and, chest, abdomen, pelvis with bone scan, then we're screening, right, with that automatically. In my patients that are getting PET CTs, those that are older, they might have, sort of impaired kidney function, or they have, if they have struggled with the prior chemotherapy, or particularly if they've had a lot of chemotherapy, those are definitely my high risk patients. I've got somebody who's getting, TDXT in a DB06 setting, but she's 39 years old. So I'm screening her because I want to catch ILD in that patient. And if it's asymptomatic, we want to treat her and challenge her back with the drug. I think we're also seeing a lot more real world data. Hope Rugo has, she's published it, and she's presented it a couple of times, that I think there's more and more comfort with re-challenging those early grade ILD patients, especially with the grade one. So grade one, by definition, is asymptomatic ILD, which we don't find if we don't screen, by the way, right? If it is symptomatic, that's by definition grade two event, and the drug company tells you to stop the drug permanently. So I think it is very important to screen and pick up those asymptomatic ILDs. Again, I think because of the small number of patient deaths that we see on every study. I will also, mention with ILD, I think a real world challenge that you bring up, Zanera, is that in a world that we operate, right? It could be like a Thursday night or a Friday afternoon call where when a patient says, "Oh, I'm having this issue," or you see them in clinic and you try to get them in for a CT, but you're so worried, you start them on steroids, right? But if you look at the guidelines and you look at what the right thing to do is, the right thing to do is to bronch that patient. But are we realistically going to bronch everybody before steroids, right? Because ultimately we've got to do the right thing. If we are suspecting ILD, or if we catch ILD on a scan and it's a Thursday or a Friday, we're not going to get a bronch on that patient, right? We could even admit them and we might not be able to get a bronch. So I think there's a lot of real world challenges. What we have done at Cleveland Clinic, I will say, I do have the luxury of being in a high volume and high resource setting. So where I have a pulmonologist whose area of interest is drug-related ILD, and we do a lot of work in TDXT related ILD. We actually have a abstract we submitted to SABCS with our single center experience, where I could call him and say, "Hey, I've got a patient," and he will pull some strings and try to bronch that patient on Friday. Or if we admit that patient, he will make some calls in the ICU and say, "Hey, I think this patient is stable. Can we bronch them ASAP before we start on steroids?" Because I think we need that data, right? We need that data. We need the gram stain. We need to rule out infection, and we need to call an ILD, and this could be a pneumonia, and sometimes it's cancer. I would say I've had two patients recently, in the last, I would say, year and a half, where I thought it was ILD. My pneumonitis specialist thought it was ILD. We admitted them. My MICU person thought it was ILD. And both times he bronchied, and both times it was cancer. It was lymphangitic spread. So I think, I just wonder every time we see these ILD called ILD, how many times are we doing pathological diagnosis to prove that it's really ILD? So I think that we really should try to block these patients is the bottom line.
It's amazing. I'm excited about your abstract, Dr. Ali.
I hope it gets in. I haven't heard yet.
Thank you so much. We
You're
also
welcome.
have one more question on TDXT. How we will differentiate lymphangitis versus ILD? That's also
Right.
from Dr. J.
Yeah. So that is the $1 million question. To my knowledge, there is no good way to differentiate that outside of the pathologic diagnosis. When we do the bronch and we get cytology, there are some signals from what my pulmonology colleagues have taught me. So for example, if the lymph count is higher, I think it's like 12% or 20%, that can be more pneumonitis ILD versus cancer. With that being said, one of the patients that I just mentioned, she had that, and we were thinking, oh, this is going to be pneumonitis. We had her on high-dose steroids. We actually had one patient we were going to use tocilizumab on, and that still came back on pathology as lymphangitic spread of cancer. So really, no great way to assess it on radiology outside of doing tissue. So I think obviously, at the end of the day, it's a clinical call, right? A lot of times we make a lot of clinical calls and you don't have access to a bronch. We've got to put that patient on steroids. And I think, a poor man's test is still okay to use, that I use all the time, is checking in on that patient and see, are you better or not? And every single one of my patients where it ended up being cancer, they said, no, I'm not better. And that could be, but the problem with that is, which I would add, which I think some of you might have experienced, that the lung toxicity with TDXD is very different than the IO toxicity we have seen, right? IO toxicity seems a lot more anti-inflammatory toxicity. We don't see a lot of patient deaths or grade 5 events with IO toxicity. So it's a lot more autoimmune, where steroids can help patients feel much better. You start them on the next day you round on them and they're like up and about. They're like, when can I go home? Like, when's my lunch tray coming? With TDXD, I think another challenge is that there's so much more airway damage. So if your patient is not better, well, is it the cancer, or is it that there was so much airway damage that steroids are not going to do anything? And there's been that handful of patients where we have considered toci. To my knowledge, we have not given tocilizumab yet for this. We came very close at one time. And once we got that diagnosis back, actually, one of them was diagnosed on autopsy, unfortunately. We decided not to do it because it came back as cancer.
Thanks. There are no more questions. Thank you, Dr. Ali.
Thank you so much for everybody's engagement. I know it's like early in the morning for some of us and late in the day on Saturday, so I appreciate for everybody's attention and tuning in. So it sounds like if there's no further sessions, Anera, I think it's okay to conclude the session.
Oh, just, I have a few more questions, Dr. Ali.
Oh, go
I
for it,
think
go for it. Yeah.
what will be the first line choice in a setting where patient isn't treated with ADC before?
So this would be ADC before, like in the adjuvant setting, in a clinical trial setting.
So the question is, in the
Do
essence,
I
what will be my first line choice in a setting where patient isn't treated with ADC before? If
Oh,
doctor,
oh, yeah, yeah. Okay, that's a good question. So the question is, if we don't have any ADC exposure and we are picking for the right ADC, so do you go for sacituzumab? Do you go for Dato? Do you go for TDXD? That's a fantastic question. I want to, I guess my disclaimer for that would be ADCs have not been compared head to head, right? And I don't think they ever will be, because I told you two of the ADCs I mentioned, they're made by the same company. To my knowledge, AstraZeneca is working on a sequencing study with Dana-Farber Cancer Center, where it's going to be TDXD Dato or Dato TDXD, right? So what is the right sequence, right? And of course, they both have the drugs and they have a vested interest and they both get to use their drugs, both of them, right? So with SG, it's made by a different company. That's made by Gilead. So I don't think we're ever going to see a head-to-head study to see which one's better. So we're going to be left with our clinical experience and our judgment. So the question you ask is, I would tell you my personal preference, or I guess my personal opinion. In my patients that are HER2 low, HER2 ultra low, I prefer to use T-DXd. I think the toxicity is much better. The oldest patient I've treated with T-DXd is 84, and she had CKD, and she did great. For the 8 months, she did wonderful. She got off the drug, and she went on paclitaxel, and she kept asking me, can we go back on T-DXd? I felt so good. So even older patients, I have a colleague who came and knocked on my door and said, hey, I've got a 91-year-old and I found her too low, I think for like lung cancer or some other indication. And we said, why don't you dose reduce and treat? And he did, and she did okay. She tolerated. So I think the point is that patients will tolerate T-DXd much better than SG. So I use it for that reason. Right now, I think the data is more robust for T-DXd earlier, right? We have DB06, we have DB04, we do have data with SG. They're just more heavily pretreated patients. That being said, Gilead's version of DB06, which is SG after endocrine therapy, I think that's the Ascent, it might be Ascent-04 study. That is going to report out either this year or next year. So again, that's Gilead, that's SG's version of DB06, SG prior to chemotherapy. So it would be interesting to see how robust that data is and how robust that response rate is, because I think that would be the best way we can do to see how good that efficacy looks. If that looks like much better than T-DXd, I think that could be practice changing. That could be very provocative. But right now, with the data available, I prefer the T-DXd upfront. Now, I think there is another sort of hiding, quite difficult question underneath that question, and that might be if you've got a HER2 low patient, but they're triple negative, and we haven't talked about that, because that's a subset of patients that are triple negative, but they're eligible to get both HER2, both T-DXd, and both SG. So what do you do there? Do you just go for T-DXd every time you find an ultra low? I would say my personal preference in the triple negative patients is more SG upfront, because the SG study, the Ascent study, the triple negative second line study, it's like a several hundred patient study, right? Versus the DB04 study that had like less than 60 patients that were HR negative. So again, we're not talking about HR positives, we're talking about an HR negative HER2 low cohort. I would say my personal bias is to go for SG there first, because the data looks more robust, a lot more patients, versus, the Destiny Breast 04, but the drug is extremely active. If I have an older patient where they prefer the every 3 week schedule, and they're okay with that goes, and I'm going to screen them for ILD, then I would do T-DXd even in HR negative patients.
Thank you so much. I think we have reached the time. Thank you so much, Dr. Ali.
Okay. Okay, thank you so much once again. You're welcome, everybody who's sharing their kind words, and this was an absolute pleasure, and thank you for your engagement. I don't have a LinkedIn profile. Maybe I should make one. I do not, but you can reach me on X, and I can drop my email address if anybody's interested. And if anybody wants to send me some support how to create a LinkedIn profile, please go ahead and send me. Thank you. All right. Thank you, Zanera. Thank you so much, and great job moderating.
Thank you so much. It was my pleasure. Bye.
Okay, bye-bye.